want to thank the organizing committee and Dr. Retno for inviting me to your esteemed conference. I'm honored to be a part of it. It has been a great pleasure to get to know some of your attendings and your staff, and I look forward to getting to know you even further in the future. So very interesting topic that you've asked me to speak on, which is very near and dear to my heart. I graduated from my fellowship in 1998, so it's been a good 25 years of a lifetime pretty much in rhinology and endoscopic sinus surgery. So I just want to take a little bit of time and share some of the things that I have learned over the last 25 years. These are my disclosures. So I just want to start by doing a little dedication to the people that really taught all of us what we do today, and our great grandfather of rhinology, Professor Walter Messerklinger, who started this whole endoscopic sinus surgery back in 1979 when he picked up the first endoscope and walked from the orthopedic ORs and walked into his OR. And that really started what we do now. And then, of course, his honored student, Professor Heinz Stamberger, who was also a very good friend of mine and a wonderful teacher who spoke perfect English and really brought this whole mindset to North America and to the rest of the world in English, because Messerklinger, his teacher, did not speak any English and only spoke German. So interestingly, I was with Professor Stamberger in Kuwait teaching a course just before literally a couple of weeks before he passed away. And it was a very sad time for all of us when he passed away. I also want to dedicate my thanks to my amazing teacher, Fred Kuhn, who I spent a year of my training with, my fellowship training with, and then spent 2 years actually working with him. So it was certainly an honor to be one of his students. All right, so let's start. So I'm going to take you back to 1988. Bill Clinton is the president of the United States. For those who are old enough and remember, it's the Monica Lewinsky era. And poor Bill Clinton was in a difficult position. And he had a reporter ask him a question. I thought he was one of the smartest people I've ever heard speak and function. And he was asked the question, who is the most important person in your life? And I thought that was such a brilliant question. And, you know, at the time he was in such hot water, and I was wondering what he was going to say to this very nice reporter who was interviewing him. And his answer was, you. He told the reporter, you are the most important person in my life right now. And it was, you know, it took her off by surprise and it really surprised me. But this is something that we need to think about. It's an excellent question and an excellent answer. And I'll discuss it further when through the rest of my talk. So lessons learned. Number one, patience. Number two, persistence. Number three, pendulum. And I'll talk about that in a bit. Remember the uniqueness with every patient. The fifth thing I learned is that we are all one big family, and I'll talk about that in a bit. I'll talk about money, and then I'll talk about learning and never being alone. And these are really important things to remember. Remember, the two most important warriors or most powerful warriors are patience and time. And always be patient and always give it time. This is about a week ago. We had just done a skull base case. It was about 2 weeks ago, actually, 2 Fridays ago. And I got this text message first thing in the morning. My resident said, the patient's name is Wendy, and the resident said, Wendy, I'm concerned, has a CSF leak. It's pretty persistent, even just with sitting up. I've sent it for beta to transferring. She might need a lumbar drain. It's moderate. My fellow replied, I would suggest Diamox. If it's persistent, we might want to revise the reconstruction. Not sure if the drain alone will work. And I woke up in the morning and I saw this and I say to my fellow, please note Please tell him not to do the tilt test and leave her with head elevated at 30 to 40 degrees. Rest. It should settle on its own. No need for a lumbar drain or Diamox. Give her another day or two. They almost always seal up. And they say it will do. And of course, the patient did fine and sealed up perfectly. But it was a great lesson as I was preparing for this talk to put this conversation on this slide, because it just shows how when we're young and we're not very comfortable in what's going to happen, if we don't have that experience under our belt, we want to rush and do things very quickly. But if you give it time, the patient will heal. The body is incredible. It's amazing. It fixes itself. And when you do sinus surgery, tell the patient, this is going to take time. It's going to take 12 weeks for the sinuses to heal. When you do a skull base case, do not rush to check for a CSF leak for at least 48 to 72 hours. Give your patients time to heal and settle. Things almost always do. Always be supportive of your patients while they recover. Never abandon them. Have a way for them to get in touch with you, because this is extremely important. I give every single patient of mine my email address so they can get in touch with me, and you'll be surprised. Out of the thousands of patients I have, I barely get emails because they don't want to disturb me, because they have so much respect for you. Always be honest, be present, and be supportive for your patients. I'll give you a little tiny story about a carotid rupture. I had just come back from my training in Georgia, and I was doing a skull base case, a pituitary case with a neurosurgeon, and I had prepared the whole site. The sphenoid face was gone, the skull base was open, the dura was ready to be opened, and the neurosurgeon mistakenly put the knife in the carotid. And it was the most horrendous 2 minutes of my life as I watched this 32-year-old immigrant Nigerian woman dying on the table. And the neurosurgeon just dropped the blade and said, she's exsanguinating, and walked out of the room. And I wasn't going to accept that. So I packed the nose, I saved the patient. She woke up completely paralyzed on one side, on her right side. And she was 32 years old. She had just moved to Canada, and she had 2 young kids. I just felt terrible for her. So I went into the room where her husband was waiting, and I told the husband exactly what happened. I sat with him. I cried with him. I connected with him completely for the next 3 or 4 months while she recovered, went home completely paralyzed on one side. About 6 months later, we got a letter from a lawyer. The entire OR staff, the hospital, the nurses, the neurosurgeon, the anesthetist, everybody was named in the lawsuit except for me. So I called him and I said, you sued everybody, but you didn't sue me. And how come? And he said, you were the only person who was honest and spoke to me properly, and I would never sue you. You supported me through this very difficult time. So remember, this is extremely important lesson. Persistence. Don't give up on your patients. If things are not going the right way, persist. Always support them. Always try new things. Talk to your colleagues. Call your friends overseas. Call the person who's done the research, and ask them how you can help your patients. I always get fresh articles that were published overnight into my inbox. And a week and a half ago, I read an article on remission in sinus surgery. And I was a little surprised because, they made it sound like it was a new thing. But really, if you look after your patients, no matter how difficult they are, and you follow them and you treat them well, they almost always, in 95% of cases, will go into what you can call remission. They will get better. Even the NERD patients, even the difficult AFRS patients, you just need to be there for them, try new things, continue to treat them, research, and you will get them better. And then I want to come to my next topic of interest, the pendulum. And this is very interesting to me. Pre-fellowship, when I was a resident, my teachers taught me to make big holes in the sinuses, do osteoplastic flaps, do Caldwell lux, drill out the frontal recess. In fact, drilling out the frontal recess was something that was introduced by Lothrop in the 1900s. And that's what we were doing in the 1980s and 1990s. Then I went to my fellowship, and Fred Kuhn and Messerklinger and Stamberger, and I spent time with all of them. And they said, Amin, don't make big holes. It's all about function. It's functional endoscopic sinus surgery. Preserve the mucous membrane. The sinuses will heal, particularly if you're very gentle and kind to them. And so that's what I learned. I became a very finesse sinus surgeon. And then comes 2020 and 2023, and we're back to stripping mucous membrane, draft threes on patients, cutting out superior turbinates on patients, big whole maxillary sinus surgery. There's very aggressive inferior turbinate reductions, et cetera, et cetera. And if I was a resident or a fellow right now, it would drive me crazy. Like, I wouldn't understand what is going on, because there are really two camps. One camp keeps telling you to be very finesse, very good surgeons, and one camp keeps introducing the drill and the debrider in the sinuses. So for upcoming residents and fellows, my little piece of advice is learn carefully, learn as much as you can, and then become amazing at what you do, because this is not your work, it's your passion. I don't want you to work a day in your life. I want you to enjoy every single day in your life. Remember, it's directed learning. And I want you to all read this book called Peak by Anders Ericsson. It is probably one of the best books you will read, because it will tell you how to become incredible at your work. Also, when you're operating or when you're planning a surgery, always ask yourself, would I do this to my mom? And if the answer is no, please question yourself. I often have residents and fellows with me, and they'll be like, let's do a mega enterostomy, let's do a draft 3, let's put a drill in here and drill everything out. And I turn to them and I say, would you do this to your mom? And they're like, oh my God, never. That's terrible. And I'm like, well, you shouldn't be doing this to this patient as well. So treat your patients like they're your family. Remember that every patient is unique. One size doesn't fit all. Doing a draft 3 on all NERD patients is not necessary. Doing a huge enterostomy on all your CRS patients is not necessary. I'll give you examples. Here is a really pleasant lady who has now been referred to me, but I went back and looked at her history. This was 2013. You can see that she had left maxillary sinusitis, and you can see the rest of her sinuses were pretty clear, and this patient had a dysbiotic microbiome in that maxillary sinus. So someone goes in 2017 and does a fairly nice maxillary enterostomy, wide open, uncinate is perfectly removed, but she still has these symptoms. The sinus is not getting better. So at this stage, she's referred to one of the young, very fancy rhinologists, and he goes in and does this to the poor patient. So she gets a medial maxillectomy, and as you can see, she did not get better, she only got worse. And this poor lady is now my patient. And if you look in her sinuses, this is what she has. She has sludge in her sinuses that drives her crazy, and she does not get better. So that's not what you want to do to your patient. So be careful how aggressive you are. Here's another patient who emailed me and said, I've had 42 doses of antibiotics, 7 rounds of prednisone, 2 skull-base surgeries. I've seen so many doctors, I can't count them all. I'm still very sick. I can't smell. I feel terrible, essentially. So if you go back and look at her history, in August 2016, she had a sinus infection from a tooth implant infection. She was a teacher, worked in a moldy building. Her IgE was elevated. All other blood work was normal. So in 2016, she had a draft 1 done by a general ENT doctor. And if you look at this, this is her pre-op CT scan. You can see she's got disease, CRS without polyposis. I don't see really any evidence of fungal disease, but she's got pretty bad sinusitis. So she needs a good sinus operation. So he goes ahead and does surgery. This is a general ENT in the periphery. And you can see, sorry, this is that same, let me see if I can find oh yeah, that was the post-op image. So this is the post-op image, and you can see things have cleared up quite a bit. She's got good aeration in the frontals, but of course, the surgery has not been done perfectly. This is a general ENT, and she needs a rhinologist. So she's referred again to an up-and-coming young rhinologist who sees the patient. And I ask you, what would you do? So if I was the surgeon here, I would just complete her sinus surgery. You can see she's responded even to a draft 1. And if she got a really good draft 2A, she would probably do just fine with good follow-up. But instead, everybody is very excited in this day and age to do draft 3s. And so this is what she ends up getting. And this is how she looks now after a draft 3, which she obviously did not need. And now she's miserable. So this is not what you want to do to your patient. She has been crippled. And this is her endoscopy. So you can see all the edema, all the pus, and you can see she's got very diseased sinuses. So I can keep going on forever, unfortunately. But as key opinion leaders in the field, we have to be really careful what we preach, and the message is getting distorted. So ability to think is an important quality for all of us, and particularly if you're going to be doing sinus surgery. So when I went to Fred Kuhn in 1998, in January of 1998, you know, things were difficult at the time. The world wasn't as small as it is now. I drove across the continent in my car to spend a year with him. And he looked at me and he said to me, Amin, why did you come here? Why did you leave Vancouver, come across the continent to me? And I looked back at him and I said, Dr. Kuhn, because I want to learn how to think. And you are an amazing thinker. And this is extremely important. Be very careful how you treat your patients. My favorite quote is from this book that you, again, should all read. The book is called Direct Read, and the author is Gabrielle Weston. And she says, a good surgeon knows how to cut. A really good surgeon knows how not to cut. And I think that's an incredible quote. Professor Heinz Starnberger said to me, it's very important to remove as little as possible and to preserve as much as possible in sinus surgery. And I added, and still to get an amazing result. And that's very important. Family. Remember, we are one big family. Your patient is always the most important person in your life during the consult and during the operation. Sit down, don't stand when you speak to your patient, even if it's just for a short time, no matter how busy you are. Focus on your patient 100% with complete attention and listen to them. No one else exists at the moment. Remember that quote from Bill Clinton in 1998. That patient is the most important person in your life at the time. Make your room very comfortable. My consult room is very much like my home. It has the same color of paint. It has very similar, beautiful artwork on the walls. Make your space comfortable. In my OR, I make it very comfortable and not intimidating at all for my students and for my nurses. Sit down for every case, be comfortable, remove shoulder strain, keep your monitors in perfect position, have a stool so your back is nice and straight and your left foot is on your stool, and turn the bed in a position that you can sit and operate perfectly. This is really important. So this is my OR, and you can see I have elbow support on my fancy chair. I have a footstool for my left leg. I have back support. I have my head in neutral position, and I have my resident sitting beside me. And this makes it very comfortable. We are all sitting down as opposed to standing and making a wall across the monitor. And then, of course, if your fellow can give you a massage, that works really well as well. So you have your monitors right in front of you, and you're looking at them without any strain, and you just want to be really comfortable and have a nice, really nice environment. Remember, the word relationship is very important between you and your patient. You should have a very easy, comfortable contract with your patient. Patients should easily be able to share their story with you. And remember that medicine is a science, but really making the patient feel comfortable is truly an art. So I'm going to come to my next topic, which is money, and be the best you can be. Because my ping pong story, I love ping pong. And when I was young, I was seeded #1 in Kenya, where I grew up, under 12. And I really loved it. But when I saw the world's best player play at one time in a tournament, I was shocked at how good that person was playing. It was truly incredible. And I realized that when you do what you love and become really good at it, someone will pay you for it. You know, whether you climb a mountain, or you make music, or you do art, or you do surgery, whatever you do, if you do it really, really well, somebody will pay you for it. And one of my patients who died from a very bad cancer, and was a Buddhist, gave me this saying that actually hangs in my office. It's right in front of me right now. And it says, your work is to discover your work, and then with all your heart to give yourself to it. And I highly encourage you all to live by these words, because they're beautiful words. So remember, do what you love and the money will follow. You have achieved success in your field when you don't know whether what you're doing is work or play. So when I look at work and I think, what is it about this work that makes it so fulfilling? Really, I think Malcolm Gladwell hit the nail on the head when he said, there are 3 things: autonomy, that means ability to do whatever you want to do without anyone supervising you; complexity, you want your work to be complex; and connection between effort and reward. So when you make an effort, you want to get rewarded. If you have these 3 qualities in your work, you'll be extremely satisfied. It's not how much money we make that makes us happy, is whether our work fulfills us. And that's really, really important. You know, an ideal scenario for us, we're all very busy, we work very hard, is unlimited time per patient, no cost constraints, unlimited resources, and no stressors. This would make our lives amazing. But none of us have these pleasures. And this is something that, you know, we have to deal with. This is my typical day. I get up at 5:30. I have teaching rounds at 7. I have surgery or clinic at 8. I end my surgery or clinic at 5. I have 5:30 p.m. rounds. I'm usually home by 7. And then I'm usually doing a lecture like I'm giving right now. So it is 6:45 in the evening right now in Vancouver. And then from 8 p.m. to 11 p.m., I do research. I email my patients. I look after prescriptions, test results, etc. So it's a very busy day. Here is, you know, just a little picture of my work day on my schedule at work. Lots and lots of patients, lots of meetings, and it's busy. And often patients will say, and my students will say, how much time do you spend with each patient? Or a patient will say, how much time will my surgery take? And my answer is always, as long as it takes. There should be no time that you keep a clock on. So sometimes the patient comes in for a quick follow-up. They know I'm busy. They'll come in, they'll say, you know, nothing's bothering me. I'm here just for a quick follow-up. That'll take 2 minutes. Another patient will come in and say, oh, I'm in trouble. You find a big infection or a fungus ball. You try to get it out of their sinuses. You flush it out in the clinic. Might take 30 minutes. It doesn't matter. You have to treat every patient with utmost respect. Learning. This is something that all of you need to do every day, no matter where you reach in your careers. Keep your minds open to learning. Question yourself. Audit your results. Learn from your failures. And don't listen to dogmas. A dogma is a condition that has been set in place by your fathers and grandfather surgeons, and nobody questions it. So when I first came back to Vancouver after my fellowship, I was like, why are we always injecting the nose with epinephrine and xylocaine? The blood pressure goes up, the anesthetist struggles, you get rebound bleeding. This is something that had never been proven. So I went out and did a study, and we found that injecting actually makes your field worse, and actually the patient gets worse. Answer a clinical question. Does elevating the head of the bed reduce blood loss? Very simple. We did a study, a double-blind placebo-controlled trial. We found that it does, and we published it. Very nice, easy study. And then the next question was, what angle is the best? So again, we did another study, and we published these articles. So you can do some really cool clinical research by answering some very simple questions. And so think about that. I'm going to end my talk with talking about recalcitrant sinusitis. These are patients like I've shown you earlier in these examples. despite everything you do, despite the best medical or surgical management, these patients don't get better. And I always ask myself, why are they not getting better? Is it that they have altered inflammatory pathways? Do they have, cytokine pathways that have been upset along the way? Or is it the microbiome? Are the bugs in the sinuses changed? They've become dysbiotic and their sinuses have become unhealthy? Or is there something else? So I always wonder, and I've got lectures and lectures on this particular topic, is it possible to reset the microbiome? Can you make these patients healthy by giving them a fresh microbiome? So would a transplant potentially reset the microbiome? And I won't tell you the whole story right now, but this is something that's become quite big in the GI world with C. difficile. So fecal microbial transplants have become a big deal. And so I thought, if fecal transplants work, would snot transplants work? So we started a study, we got funding for it, and we've currently got a study going with 40 patients in 2 arms. It's double-blinded, placebo-controlled. One is getting transplants by itself, and one is getting placebo. I don't know which patient gets what. But this is a typical patient. This is our open label study, the first 9 patients that we did. This is pre-transplant. So this is her right maxillary sinus. You can see the pus and the sludge in the right maxillary sinus. This patient has had disease in the maxillary sinuses for the past 22 years, and she is not getting better despite very open sinuses. And I'm very reluctant to do a mega antrostomy or medial maxillectomy in her after seeing what I've seen happen in other patients, and she is refusing to have that done. So how do I get this patient better? So this is her before the transplant, and this is her 6 weeks after getting a healthy transplant from her daughter. She's completely cleared up and getting better. And you can see the edema continues to improve. Her name is Colette. And I took this video today. She's 14 months post-transplant. And I want to show you how she looks today. She looks incredible. She's completely cleared up. That's her frontal sinus on the right side. And her sphenoid on the right side. And then I'll show you her diseased maxillary on the right side. It is completely clear. All her symptoms are perfect, and her SNOT score is down to 0. Very, very interesting. This truly humbled me, this research. So I continue to learn. It's been a lifetime in FESS. I've only been doing it for 25 years, and I hope to be doing it for another 25 years. And it's just been an incredible journey, and I continue to learn. And I thank you for inviting me to speak to your meeting. And this is the view from one of my ORs. If you ever get a chance to come visit me and spend some time with me, I would truly be honored. Thank you very much.